Thank you everyone for your time today. We're starting the webinar as of now. Let me welcome first our speakers today. We have a very interesting seminar prepared by our speakers, and let me introduce them to you. We have with us Dr. David Grubbs. He is a senior policy researcher at the RAND Corporation, co-director of the RAND Center on Decision Making Under Uncertainty, co-director of the RAND Climate Resilience Center, and a professor at the Purdue RAND Graduate School. He's a key developer of new methods for decision making under deep uncertainty and works directly with organizations worldwide to improve their planning for the uncertain future. He focuses on climate adaptation issues facing water resources and coastal planning agencies. He's also working with the development banks to ensure that decarbonization is implemented successfully across different regions. Dr. Grubbs received his PhD in policy analysis from the Purdue RAND Graduate School. Dr. Raffaele Vardavas is an associate mathematician at the RAND Corporation and a professor at the Purdue RAND Graduate School. His modeling work includes both vaccination and use of antivirals, modeling the coupled dynamics of seasonal influenza epidemics and agents' behavior towards vaccination using an agent-based inductive game approach. His other work in health includes healthcare utilization forecasts, illicit drug use, and cost to society, and then compare health policy simulation project that models the impact of healthcare reforms. Non-health projects include constructing a game theoretic evolutionary economics agent-based model on carbon markets to project the impact of different climate change policy alternatives. Dr. Raffaele Vardavas received his PhD from the Imperial College of London. Pedro Nascimiento de Lima is an assistant policy researcher at RAND and a PhD candidate at the Purdue RAND Graduate School. And his primary research interests are the policy realm applications of decision-making under deep uncertainty methods. Just a reminder to everyone joining today, we are discussing today COVID-19 and deep uncertainty methods. And without further ado, before we start, just remember visiting the website for the annual meeting. Please join us and revise so you can submit your work. Without further ado, now I pass it on to our speakers today.
All right, can everybody hear me okay? Edmundo?
Yes, we hear you well.
Okay, great, thank you. Well, good afternoon, everybody, and thank you so much for joining us for this webinar. First of all, I just want to say I hope everybody is staying safe and coping okay with these challenging times. And of course, we're going to be talking about one of the underlying drivers for the times we live in, COVID-19, and talking particularly about how DMDU methods can be useful in thinking about policy responses and recovery. Let me also thank Edmundo and his colleagues at Tec de Monterrey for putting together this seminar series, and we're really honored to be participating. Let's see if I can advance. Okay, great. So, you know, the title of this slide is Responding to COVID-19 Under Deep Uncertainty. So what I'm trying to motivate here is that, thinking about how to respond to COVID-19 is obviously an exercise in planning under uncertainty. And I think that, as is the case for some longer term problems like climate adaptation or water resources planning, this type of problem also, includes elements of deep uncertainty. So for instance, addressing the questions of how can COVID-19 restrictions be relaxed in a way that balances restarting the economy with managing the rebound of cases. There are many, many factors that will affect how well a strategy performs in trying to strike that balance. And so, we need to really understand the implications of those uncertainties in order to perhaps make the right choice. Another question, when and how should restrictions be reapplied if cases increase too much? Do you crank back down the restrictions to the prior level, or is there a gradually increasing restrictions again to bring cases down? Again, there are lots of factors that we'll describe that make that question very difficult to address. Other questions like how should testing be deployed to inform policy directives? Again, face questions of deep uncertainty. So, obviously this is a seminar series on deep uncertainty, methods for deep uncertainty. And so, we think that some of the approaches that, our group and others in the community use can be really helpful. Okay, so today what we're going to do is, I'm trying to advance the slides. I don't know why it's not advanced. Oh, okay. So today we're going to, I'm first going to describe briefly a DMDU method called robust decision making that we're using to think about COVID-19 policy responses. Then I'm going to turn it over to my colleagues that are going to get into the details of a specific COVID-19 tool and epidemiological model that they created to inform or to evaluate how how well the policy responses would play out. And then we will focus on describing some initial robust decision-making results, or describe an analysis that we have underway. And then we'll end with some questions and a discussion. All right, so let me just, for those of you who are new to the community or who haven't heard much about robust decision-making, this is one of a variety of different methods under decision-making under deep uncertainty. It provides an iterative framework for evaluating what would happen under many, many futures and testing different strategies, primarily looking for those strategies that are robust, or in other words, will perform well regardless of how the future unfolds. The graph on the right shows this iterative process, beginning with a decision framing step, and then going through an evaluation of strategies, a vulnerability analysis, a trade-off analysis, and the iterative development of new and often adaptive strategies. So, this is a quantitative method. So we, it's often based on, quantitative models of the systems of interest. So in this case, the development of COVID-19 and the policy responses and economic outcomes from those. A quantitative vulnerability analysis is used to help us understand which uncertainties drive outcomes of interest, whether that be, favorable outcomes, low deaths, low impacts on the economy in this case, or cases that are undesirable, such as high deaths or high economic impacts. And that vulnerability analysis provides information to help us develop more robust adaptive strategies. All right. The way that we often go about designing and developing these studies is gathering stakeholder input. In this case, for COVID-19, we of course didn't have time to talk to people about what's important. Is very clear from the papers and everything that's going on, what the types of issues that we want to explore are. But regardless, in a robust decision-making study, we often characterize all the elements of the study and using an XLRM matrix as shown here. So in the upper left corner, the X corner characterizes or describes the key uncertainties. So which uncertain factors in this case influence the progression of COVID-19 and the effects of responses. In the upper right are the policy levers that decision makers are choosing among. So social distancing issues or measures, capacity for testing, transmission reduction measures, as well as adaptive strategies. And then we think about how do we evaluate the success of those strategies in terms of performance metrics. In this case, we're looking at disease-related metrics and economics-related metrics. And then the lower left captures the relationships, or how we tie these factors all together. And in this case, it's an epidemiological and economic model. And I'll let Pedro describe that in much more detail. So before I move things over to them, I just want to highlight a little bit about the importance of developing a model and the value sometimes in RDM and helping evaluate the model. So when thinking about COVID-19 and its effect on, of course, the progression of the disease, or the epidemic, as well as the economic impacts of interventions, you can imagine that there's a lot of things at play. I mean, there's of course the what's going on with the disease in a population, but then there of course is how the economy is going to respond to different measures, and that requires thinking about modeling as an integrative exercise, bringing together different representations of different parts of the system and bring them together into a single package that can trace out what would happen if you do this, what would the outcomes be if you do that. But of course that process introduces lots of uncertainties in the process. So I just want to highlight that what we're going to be talking about next is essentially a scenario generator that my colleagues developed to evaluate how COVID-19 would evolve under current policies, understand what the health and economic impacts of different outcomes would be, and what if the restrictions are relaxed, or how would things evolve depending on different schedules of changing restrictions, et cetera. So with that, let me turn things over to Pedro, who's going to talk about the underlying model and a decision support tool and an RVM analysis that we are in the process of working on.
So hello everyone. Here we will first ground our discussion and think about the components of the decision support tool that we created. Most of our discussion will be focused on the epidemiological model, but it's important to have an overview of everything before diving into certain aspects. So we structure our tool around these NPI portfolios. NPIs are non-pharmaceutical interventions, and they are made up of individual NPIs. So we have a set of things or policies, non-pharmaceutical policies that states can enforce or can suggest, and these make up these NPI portfolios. And then what you can do in our decision support tool is that you can choose the location in which you will apply one of these portfolios, the NPI portfolio itself, and the duration. And these decisions are fed into two separate models. There is one epidemiological model, and there's the economic model. And both models produce certain estimates. In the case of epidemiological model, they will be the health outcomes, and the economic model produces a gross state income loss based on these interventions. So what do these interventions mean? So in order to aggregate these interventions, we chose to form portfolios, and we have 5 levels of interventions. So at the first level, we can close schools. At the second level, we can do that and close bars and restaurants, all the way to the level 5, in which you you ban large events, close non-essential businesses, and also issue a shelter-in-place order. So these are the interventions that are being used by our model. Now, we want to ground our discussion here on the structure of the epidemiological model, and I believe that doing so is really helpful for many reasons. One, because once you start and think about the structure, the causal mechanisms that are in place, it really helps bring some clarity in what's going on. And it's also interesting to see that many of these stocks, many of these states are really uncertain values that we really don't know even now. So this is the general structure of our model. And Raphael, if you're listening, if you want to chime in, please just speak. You don't need to wait me until I start. So so this is the structure of the model. Each one of the circles represent certain states. So you can imagine there are people who are susceptible to the virus, people who are exposed, then there is a primary infectious stage, and then they progress through the system until they're either recovered or dead. What's interesting about our model, and it really helps to understand what's going on, is that our model separates the states in different stages. So ISM means that these people are infected and they're symptomatic and they have mild symptoms. ISS means they are infected, they have symptoms, and they're severely symptomatic. And Y here means that these people have been tested, and that has some implications for how they behave in our system. So our model can consider that people who have been tested will be more cautious and will be less infectious to other people. Our model also considers the fact that people might be asymptomatic, and they can also be tested, although it has not been the case so far in the United States at least. This can be represented by the model, and people in these buckets you got are also divided in age groups. So we have young people, old people, and people with chronic conditions and people without chronic conditions. So this is the basic structure of the model.
Right. So Pedro, I wanted to mention, this is Raf. We have the primary stage of infection, which is the P state, and that's an infectious state as opposed to E. We thought that this was an important stage, and we'll talk more about that perhaps, because this is the stage where people are not sure, it's not sure if they're going to be asymptomatic or asymptomatic, but this is where people, if they get tested, there would be many false negatives, and it's important to model that component because a lot of transmissions might be due to both the primary and the asymptomatic stage.
Yeah. So with that in mind, we just want to highlight some of the key features of this model. So this model considers heterogeneity. So we have 10 population strata, 5 age groups, and 2 health status. And this really helps model what happens if you impose different interventions to these different population groups, and also the outcomes that happen today. The model also considered 3 constraints. One of them is testing capacity. So in the real world, you don't have a way to observe people in all of these states. In fact, at this point in time, for instance, we really don't know. We don't have precise estimates for all states of the number of people who are recovered, or we also don't know the number of people who are asymptomatic. So you can see that it's really hard to manage a system where you don't have a precise measurement of each one of the states. So the model models that. So the way testing capacity works is that it's distributed to the more severely symptomatic people up until you are able to test asymptomatic as well. The model also considers hospital bed capacity and ventilator capacity, meaning that if we have a severe constraint here, people who are severely symptomatic die at a different rate. So the model also considers this aspect of the problem. And also
Sorry, Pedro, I saw that there's one question, and why we selected this model compared to other compartmental models. I mean, this is an SEIR model fundamentally, where we have, it's a S susceptibles, E, the exposed, and then we have a big, infectious stage where there's multiple stages where we have broken up the infectious stages into those states which are key to COVID. So based on our discussions with MDs and the literature, we identified what were these stages, and there might be other states which we might want to consider. For example, one of the things that is missing here, and we're considering to putting in, is people who come out from the hospital apparently once they recover might still have some be a little bit infectious still, and so you might want to consider another compartment there. So we're still revising this model. I mean, we have a version, but we're adding things. But this is the general idea of why we've constructed the model this way.
Yeah. Okay, so moving on, we have the missing matrices. So Raf, do you want to take over here?
Sure. So, okay, so exactly, we have those population stratas by age group and health status, so 10 of them. But in order to model the interventions, there's a mixing matrix, obviously, between those different population stratas, but also to how are people mixing, and you can mix under different mixing modes or activities. This might be household, work, commerce, leisure, the school, and in order to get this these mixing matrices, we use well, two data sets. One of the data sets primarily it's a synthetic population data, network data for Portland, Oregon. Has been used multiple times in epi models, specifically to model seasonal influenza. And so it has basically 1.6 million or so individuals for Portland, and it provides data for, well, it's a synthetic population, so it's not real data. It's based on different data sets to construct this context, but basically it provides an edge list of the individuals on that network, and the time, the number of contacts, so between the different individuals, and the durations, and under what circumstances was that contact formed. So so we can use that data to construct these mixing matrices, which describe the way people are mixing under normal conditions, the status quo. But then we can basically dial down, let's say, the weights associated to each of these different levels of mixing to describe different NPI levels. And so exactly as we reduce leisure, we reduce commerce and these activities, by what element, or what's the weighted reduction in mixing at those levels. So by doing a new weighted average between those mixing levels, we can come up with a new overall mixing matrix.
Yeah, exactly. And what that helps us to do is to give some more realism to the NPI interventions that are out there. So by using mixing matrices, we can be more explicit about how NPI changes mixing, and therefore infection, and therefore the dynamics of the disease over time. Yeah, so this is the fundamental mechanism behind the NPIs and behind our model. Right. So one of the questions we get is, there are simple models out there. The standard model is the Sevier model. Why all these details matter? Why should we care about, specifying different states and different diseases stages? So one of the reasons why is that it turns out that if you don't consider that we have different stages, and people at these stages can mix and can infect other people at different rates, you might end up with a very misleading model. So in our model, we consider the primary infectious stage and the asymptomatic stage, so that if you enforce, for instance, a policy on individuals who are hospitalized or severely symptomatic, these people will still mix, and they will still you still infect others. And actually, it turns out the World Health Organization just issued a one of their public health officials said that now they believe that asymptomatic people don't drive a lot of the infection. It was really recent, and there is some disagreement about the extent to which people who are in this bucket drive new infections. So by having this stage here explicitly in our model, we can run sensitivity analysis, and we can say, even if we don't know precisely how they mix and how they infect, we can run our model under different circumstances and see how sensitive our results are to this assumption. So by having this model, we can explore how sensitive our results are to these different assumptions. Okay, so how this actually works in our model. So this figure helps understand how our model works. I hope you can see my mouse here. So in the first variable we have here is portfolio ID, and this means the intervention level, meaning that a low number means that we are reopening the economy essentially, and a high number here, 16, full lockdown. And this is the time series for a given state that we've been tracking. And this run, what it does is that it simulates this state reopening, going from level 5 to 1, staying there 90 days, I believe, and then locking down again. And then you can see how this has a delayed effect on the other variables. So the first thing that happens is that these changes, they are effective instantaneously. And as infections happen, you have different numbers of people being infected. So you have a huge number of asymptomatic people infected in our model, and then a smaller number severely symptomatic, a smaller number who have actually been tested, and then people who ended up needing hospitalizations and then deaths. So that's how. So that's how the model works. Okay. Another point about our model. So this is how the non-pharmaceutical interventions are. Do you want to say something?
No, I just want to say that this is a model, and we won't talk too much about that. The economic model, is that where we're going? Yes.
Yeah. So this is just to give people a sense of how the economic model works. We have a link to the report, but this is not really our focus right now here at the webinar. So the non-pharmaceutical interventions, they basically can be mapped to closing or shutting down sectors of the economy. And then you can estimate the impact of shutting down the sectors on indirectly impacted sectors as well. And the general equilibrium model by Aaron Strong and Jonathan Welborn, track these impacts. So the same interventions that we've been discussing in the epidemiological side are applied here in the economic model. Yes, so just to give people a sense of how our model stands compared to others, so that media coverage on some of these models have been significant, and one might wonder, why do these models disagree? And so the answer to that really lies on how models have been built, and what are the questions and the outcomes that the model considers. So our model is, you can think of our model as a systems dynamics model. It's more explicit about the causal mechanisms that drive behaviors, and our model also considers economic impacts. So this is a high overview of our model compared to others. Comments here, Raf?
Comments, it's basically statistical models. I mean, are very different from, the systems dynamics that models that our model belongs to, and it's based on the curve fitting. So but at the moment, there's really only these two things out there. There's a hybrid model, and we're waiting. I mean, I think they're developing agent-based models too, but those take a little longer to develop, as they're much slower to run, right?
Yeah. Yes. So this is what is behind our web tool. You can go to that link. I believe it's on the front page of the RAMP website right now. Here's the report if you want to have more details. So the way the tool works is that you select the intervention state. So, for California, for instance, if you start on intervention level 4, you can choose to which level you go, and then you can also choose when you do this, and you see that both levers make a significant difference in the outcomes you measure. One interesting thing and one interesting comment that we get from our model is that, sometimes people see huge uncertainty bands. And the reason why that is the case is that being a system dynamics model, in this case, you are saying that, I think here is New York. Yeah. So New York will basically reopen, and the model predicts a big rebound after this reopening. And the reason why you see this big uncertainty band is that really, once you start working with system dynamics model, you see that the feedback loops really take over the system behavior. So if you are on the edge of a new infection, if R effective is really close to 1, just small changes in these parameters can make a big change. So that's why you see these kinds of behaviors, and really statistical models won't produce this kind of nonlinear behaviors because they don't have these feedback mechanisms built into them. Okay, yeah, and this is just an overview of how this thing works. I won't spend too much time here, but the idea is that we get data from APIs, and then there's an analytical pipeline so that we can have these results out there. Yeah, so our model is not perfect. There's the saying, our models are wrong, and some are useful. I would also add that some are misleading. And the work that we do really is what are the key limitations that should be revised so that the model becomes more useful to an RDM analysis. So currently, the results that you see on the website don't consider seasonal effects, don't consider loss of immunity, behavioral feedbacks, and improvements in treatment or the introduction of vaccines, and also really don't tell you what is behind these uncertainty bands, and also don't really allow us to build adaptive policies. So that's really what the next step that we're taking right now with using robust decision making with this model. So let's go over the RDM, and then we answer all the questions. Yeah, so now our goal really is to evaluate additional uncertainties, test a wide range of interventions, not only the ones that you see in the web, to understand what assumptions we need to hold for specific reopening policies to strike a quote-unquote good balance between health and economic outcomes. We know that this is really hard. And identify adaptive guidance for managing the pandemic. And this is an XLRM, a more detailed XLRM. And the key point here is that our current model and other models out there really don't usually, embed all these uncertainties for several reasons. And as we will see, as the future evolves, some of these uncertainties could be significantly important in determining the long-term outcomes that we'll see going forward. So the work progresses as we add these uncertainties and these new levers to the model and then explore the results. So I can show a little bit of the results, the preliminary results we have. These are not final, and they're just here just to give you a sense of what are the outcomes of this analysis. So what we can do with RDM is that we can take one policy and then explore it over a wide range of futures. So this is the same policy that I showed before. And then what you can see is that simply reopening the economy and then closing again is consistently bad across many futures, even if we relax some of the assumptions. Another thing we can do is also add, different strategies. So you can see one strategy that reopens the economy as soon as possible, and another that waits a little bit and then do that. And what you can see is that you get different spikes with different orders of magnitude. And in this particular run, you get a significant number of deaths, even if you stay under this intervention for more time. And what's important here to note is that these outcomes will be shaped primarily based on the availability of vaccine, availability of treatments, seasonal effects, low immunity. These things are being incorporated in the model. And then what we can do is that we can take one policy and explore, and then over a range of futures, we can compare policies, and then we can do that at the same time. And this is one of the particular policies that we're exploring. And then we can ask the questions, under which conditions we get, significant amounts of deaths. And for this particular policy, we are already seeing that the NPI effectiveness factor, or compliance, is one of the driving uncertainties that will shape future outcomes as well. So here, I just want to make a few points. So the outcomes of the current policies that we've been seeing will vary depending on a number of uncertainty factors. And with RTM, instead of making our model a better prediction machine, we use it to stress test these current policies, identify these conditions under which they may not work, and then use this information to develop better and adaptive policy responses. Yeah, so these are our slides. Now I think we can use this time to answer more questions.
Thank you very much, Pedro. Thank you very much, Dave. And thank you very much, Raf, for your presentation. Definitely very interesting work. I have a lot of questions on the chat, so let me go over them. And for the rest of the audience, remember that you can virtually raise your hand, and then I'll see you do that, and then I'll give you the opportunity to ask your question to the speakers, or you can continue writing them down on the chat, or as a last resort, you can unmute yourself and ask the question directly to our speakers. So I have a question here that says, can you calibrate the model parameters using mobile data to infer the degree of social distancing?
So Pedro, shall I take that?
Yeah, you can take that. I can add my comment, but
okay. Yeah. So mobile data, we have been in a separate project, which we want to actually add in behavioral impact. We have been considering mobile data and how people before, the lockdown and after the lockdown, compliance to that in terms of mobility for the different states. By the way, that the model is actually calibrated to deaths and mainly the deaths, but we have also confirmed cases for each state. So we do a calibration for each state, and each state is modeled separately from each other because we're no really longer, of course, at the early phase of the infection, where the seeding between states is kind of important at this point. So we calibrate each state independently of each other. But we are looking, and we have considered the mobility data, but the mobility data not necessarily to calibrate the model for the contact rates. So the contact rates are informed through this data set, network data set, and we dial down the mixing external to the model, basically, rather than what we want to do is from the behavioral model that we have, the analysis that we're doing in terms of how people's mobility, people's mixing changes as a result of perceived risk, which would be so it's a time series analysis between the mobility and the case fatality or perceived case fatality rate. And by creating a statistical model between the two, we would then input that into the model in an endogenous way, where the contact rates would change, or compliance to the interventions would change as a result of model outputs.
Thank you very much, Rafa.
Yeah.
Pedro, do you want to add something?
I also want to add that oftentimes the data that we have is not necessarily the data that represents infection. So, one can argue, yes, mobility data could be a good proxy, but that might be the case when the pandemic started and no longer the case now, because people are, traveling, they're using cars, and they are wearing masks. So how do you disentangle these effects? And if you just use mobility data without thinking about that, you might, use the wrong data to calibrate your model. So I'm a little bit wary of, approaches that use whatever data is available just because we have this data.
Thank you very much, Pedro. I have a long question from Stephen Roy, and Stephen, I'm not sure if you'd rather ask the question yourself. So if you'd rather do that, then you can just unmute yourself, or if not, then I'll just go ahead and read your comment.
Yeah, thank you for a very interesting presentation. I work in the ICU. I'm a ICU fellow in Calgary. And my question is whether you've considered defining, or if you've defined what an asymptomatic patient in the model means. The reason why this is relevant is because we have a lot of patients who will not have COVID precautions taken in the same way when they present, quote unquote, asymptomatic, but they're actually presenting with symptoms. They're presenting with symptoms that are not respiratory symptoms. So for example, patients coming in with a stroke. I took care of a very young patient with a stroke, which never happens. And I tested him for COVID, even though he had no respiratory symptoms, because I felt that he was at high risk. We know there's hypercoagulable state. So there's these patients who come in who may not have the same precautions taken, who come to a node of very high risk in terms of affecting the capacity by infecting healthcare providers, but also infecting people who are have chronic diseases, but they're not symptomatic in the sense of like respiratory symptoms, and they're going to be treated differently by the symptoms or by the system, sorry.
Right. So the way I think so symptoms, we defined the mild symptoms was anybody who developed a fever and a dry cough. And from the mild symptoms to the severe symptoms, it would be exactly the developing the respiratory symptoms and difficulty in breathing. And at that stage, if they can, if the hospital is not at capacity, the vast majority of them would basically be hospitalized because, yes, and not necessarily go to the ICU, but they would be hospitalized. So asymptomatic, I believe, and it's been a while since, I believe it is indeed showing not producing fever nor having a dry cough, and the way I think our average proportion of people who we assumed were asymptomatic, although there's a big uncertainty here, we went for the one which was the 35% quoted by CDC, but there's again, but we have a lot of heterogeneity. We assumed a lot of heterogeneity age, heterogeneity. So it depends on age. So when we put the heterogeneity's age and whether someone has a chronic disease, that really impacts mortality, but also specifically the probability of being asymptomatic. I'm not sure if that addressed your question, maybe partially.
Yeah, so what it means is that we have patients who I would define as symptomatic that the model will define as asymptomatic. So patient coming in with a stroke or with a blood clot in the leg that brings them to the healthcare facility, but they are in your model asymptomatic, but they can transmit the virus and are likely to come to a node of high risk to society, and not necessarily have the same precautions taken with them because they're asymptomatic, as opposed to the asymptomatic person in the community who is going to infect largely healthy people who are not healthcare providers.
Right. Yes, that's true. I mean, there's and Pedro, I think you want to add, but yes, I mean, being a population level model, meaning it only tracks population densities, not individuals. Therefore, or individual trajectories. It doesn't account for all the potential heterogeneities that we want to or would be interesting to put in, and so we're limited by, of course, in order to have it a fast model which can consider many different states and combinations of parameter values, we opted for, as many other groups, for a population level model. But agent-based models are being developed, and those can consider a much wider range of heterogeneities.
I would just jump in here real quickly to just highlight that this kind of question is illustrates sort of one of the strengths of applying a robust decision maker, a DMDU approach, because it's suggesting that there's a different interpretation of how the system, or in this case the disease progresses and is transmitted. And so depending on there are different ways, and I'm not the expert here at all in representing that in the model. It may be a changing a parameter value or introducing another classification of patient or whatnot, but the iterative approach really is designed to accommodate that sort of thing. So as you see results and you're like, well, that's interesting, but I'm really thinking about this ignored factor, I wonder if that matters. And that's a great question to have, and that doesn't mean the analysis is wrong. It just means the analysis might need to do another iteration. So thanks so much for that question.
Thank you very much. Let me just go ahead and go to the next question. For the economic model, did you model economic losses due to the individual behavior changes not related to an imposed intervention? Some data shows that people stop traveling on their own, for example, regardless of government restriction.
Right. So, Pedro, obviously you can intervene. We didn't develop the economic model; it was another group. But as far as I know, that's not the case. The economic model are all these direct and indirect, without necessarily the heterogeneities or a feedback loop between outcomes and the behaviors. Yes, it's true. Looking at the analyses that we are on the mobility data that we want to use to inform this model with a behavioral feedback loop, once we've put that in, we do notice that there are people who right away respond to those risk perceptions and change mobility in a like an exponential way. Let's say as soon as risk perceptions increase, their mobility decreases into a new level in an exponential form. And then instead there's another group of people which instead the change is more like an inverted S curve. So it's kind of flat, and then all of a sudden it starts to respond. Maybe either that's a behavioral aspect, or it's a combination of the behavior and economic aspect in terms of people can't afford, of course, to do physical or social distancing until it's more like at a later stage.
Yeah, I want to add to that, because this is one of the issues that we've been working on over the past months and talking about all the time, is that how do you model long-term behavioral changes induced by COVID, but and how do you disentangle that from the policy interventions? This is really hard. We are working on that at the epidemiological side through changing not only the rate at which people mix, but also how transmissible they are when they do mix. And this will probably become part of the RDM analysis that we're doing. But an even harder task is how do you model this long-term transition to this new economic model? I don't think there are many good answers to that. I think, and our model really is being a general equilibrium model. It assumes an instantaneous rebound as well. So yeah, so these are the assumptions that are being used.
I just wanted to point out, just to clarify, that when Raf said the economic model was developed by another group, that just means another group of researchers at RAND. So it is part of the overall study that you can read about at the link that I put in the chat window. So just wanted to clarify there.
Yeah, that's right. Sorry. Yeah.
Thank you very much. I have a couple of questions here about calibration. Let me just read them to you. It seems your model is based on several dozens of parameters and regions. How do you calibrate the model? And also, how do you calibrate the model for such a complex phenomenon?
Pedro, would you like to take that, since you work most on calibration?
Yeah, so the calibration process uses the time series of deaths. When available, we also use the number of cases, and that will be a complicated process to explain fully in detail here. But the overall process is you take the early phase when you have deaths and you don't have interventions, and with that for each state, and with that you can back out the growth rate at the exponential phase of the disease, and you do that for every state, and then you use the NPIs, or the interventions that they've been applying over time, and then you simulate the model in the past, and then you choose parameters that best fit the time series over the past. And then, yeah, so that's basically the overall process. And you do that for every state so that you capture differences between states.
So, and can I just add, because I think there was another question related to the basic reproductive number, the R0.
Yes.
Yes,
not
so,
yet.
so exactly. In the calibration phase of the early stage, that's the disease invasion, where there's like the exponential, that's where we get the growth rate. And indeed, by calibrating to deaths, mainly we go through a stage of, prioritizing calibration to get the deaths, and then we go to the case counts. But, and if really the data is really bad, so there was some states where, then we basically find a R naught between in a min to maximum range, and choose an R naught which is based on the population density of that state. But that's really like in the extreme case where the data is not good enough to get any fit. But yes, we get the R naught, and so the R naught is different for each state. And also we analyze the model, but we use the next generation method to get the analytic form of the R0 or R naught. And so we from the parameter values, we get the R naught value, and then we do a calibration of what is the a calibration factor which we need to consider, which changes that in order to reproduce the deaths.
Thank you very much, Raf. Let me just go ahead to a new question from Homero Paltan. How do you account for the uncertainty in the parameters of your model? Isn't the model and outcomes too dependent on human and societal behaviors which are indeed uncertain?
Pedro, do you want to say the uncertainty? Yeah, okay.
Yeah, exactly. So when we, so there are two approaches that we use. First, when you calibrate your model, we just don't use the best fitting line. We use a set of lines. And these different trajectories really capture different hypotheses about these uncertain factors. For instance, you can calibrate the model, you can pick one of the trajectories where people are really complying with intervention, and there you don't see a big seasonal effect or the contrary, and then we can test this hypothesis during the calibration phase. And that does give you a rich set of runs to analyze and run into the future. But on behavioral uncertainty, we do that by not fixing parameters that we don't know. For instance, we don't really know what is the exact effect of each intervention. So you don't want to use a single value for the intervention effect. So what you do is you use a distribution that you specified previously. And the process really depends on the model structure, because if you have a really simple model, you can't relax some assumptions, right? So it's an iterative process where you have to not only change parameters, but sometimes also the structure of the model itself.
But I just want to add that, exactly within one segment of time of those interventions, we calibrate the model based on these probably distributions, etc. But we assume that within that time segment of that MPI being effective, that's how people are going to be behaving. And this goes back to the fact that we're missing an endogenous behavioral model where people instead might change behavior or compliance to the MPI, or there's fatigue, etc. And these are all things which would be nice to bring into the model, but for now it's exactly assuming that for this segment of time, this is what the intervention, and this is the mixing matrix. That's what we're doing in the model.
Thank you very much, Raf. I have another question here from Diego Rodriguez. How do you see this working in an environment with weak data? How long can it take to apply this in a developing country context with limited information?
How long? Well, we are going to, we might be have the opportunity to adapt this model for India soon. And so we'll soon find out in terms of the data. We're going to go for first two major geographical regions before we extend this, so there will of course be a big uncertainties. I don't know, Pedro, you wanted to
but I want to say that it's not just take the model, plug in your data and hope it works. Probably it's not going to happen this way, because the data is collected in different ways in different countries. You don't have the same types of data. So it definitely is a question of, you'll probably have to change your calibration process to account for the data that you don't have now in this new situation. So that's, this is one of the reasons why it's just hard to take a model that was created for US states and even apply it to counties, because you don't have the same kind of data and so on and so forth.
Okay, so let's, I have one final question here, and with that we will wrap it up. This question from Mikhail Sirenko, who has been asking a lot of interesting methodological question. He's basically kind of asking if your calibration method is not leading to overfitting.
Pedro, do you have any, do you want to?
So this overfitting is about fitting a model structure to data on which the model was trained, and just because the model fits this data, it doesn't mean that it can explain other examples. In the case of other examples, you can think about explaining the future rather than the past. Well, from what you can see in our web tool, you can see there are runs use a rich set of runs. We don't just pick the best fitting line and use just that. That probably would lead to overfitting. I mean, that could be interpreted as overfitting. What we do instead is we take and run a set of runs into the future. So you have a sense of how sensible or sensitive the outcomes are to these different runs. So in the side of erring of more overfitting or less, I think we're erring on the side of less overfitting by using this rich set of runs and not only taking the best fitting line.
But one thing which I don't think we have done, which we could do, of course, is to see when the calibrated models for the different states, we specify parameter values and ranges for those for each state, and then we calibrate the model for each state. To what extent the calibrated models or the reduced set of parameter values are in agreement across the different states, and so that might be some way of seeing, if there's wild differences and they're not an agreement, then it might be that that they're considering certain parameters which are very specific for that state. So these are things which we should do. I don't think we have done that, Pedro, but we can look into.
Okay, and with that, we conclude this webinar today. And actually, we conclude this webinar series. Pedro, David, Raf, this was a wonderful presentation. Without question, a very interesting topic, and I'm sure a very prolific area for DMDU work and research. Please, everyone has joined us today. Don't forget to visit the DMDU website. Let me just post it one more time here. So you can learn about our call for abstracts. Make sure you submit something in the coming days. So please visit our website so you can learn more about our 2020 annual meeting. Make sure you submit your work. We're looking forward to hear from you. And with that, I thank our speakers today once more, David, Pedro, Raf. This was a wonderful presentation. Thank you very much for your time. And thank you everyone that was there here with us today.